Well, good day, everybody. This is Chris with the Ancient Scholar. I hope this video finds you all doing well. In this particular video, I'd like to take some time to address an older video of mine that has had a lot of contentious discussion. Nothing unprofessional per se, but rather contentious, and it's not clear to me if some of the discussion is coming from maybe a place of ignorance or perhaps individuals being a bit flippant. But whatever the case, I'm not going to be a mind reader. Whatever the case, I think it still justifies some discussion. The video in question was posted about 5 years ago, and it is NREMT Psychomotor: Static Cardiology Part 4. And this is going to specifically reference a stable, wide complex tachycardia. This was monomorphic ventricular tachycardia. And in that particular rhythm, I had mentioned considering the use of adenosine. And this, I think, these are the most contentious comments surrounded the use of adenosine. So what I want to do is I want to preface the rest of this video with a couple of points. Point number one, the entire video that I made was in reference to the National Registry of Emergency Medical Technicians Psychomotor Skills Examination for paramedics. In that particular exam, the process of the psychomotor, the hands-on exam, is to determine baseline or minimal competency of paramedic candidates. All right? That's very important, because when a paramedic candidate comes in and they have to identify rhythms, we're looking at basic core baseline competency. All right, they are not looking for high order discussions about, is adenosine going to be therapeutic in certain cases, or is it more diagnostic in other cases? That's not the point. Really, the point is, can these candidates identify basic rhythms, and can they regurgitate the basic foundational therapies that we would expect all entry-level paramedic candidates to possess? All right? So what we're really looking at as a baseline is advanced cardiovascular life support as outlined by the American Heart Association. All right? Point two, I fully identify and accept that there are issues with AHA guidelines. In particular, the guidelines are primarily focused around, shall we say, middle-aged or older adult male patients like me, all right, who have some underlying cardiovascular disease, and that is approximate causation of their rhythm disturbances, right? They have ischemic cardiovascular disease and all of the problems that ensue. That's really what ACLS guidelines deal with, right, when it comes to dysrhythmias and even cardiac arrest. Okay, so it's kind of bread and butter, milk toast assessment and management of cardiovascular disorders. All right, so they do fail to take into consideration a lot of high order thinking and nuance that comes with cardiac rhythm interpretation and treatment. And I fully acknowledge that, but that's not the point of the NREMT psychomotor exam. It's not the point to have high order discussions and to opine on more esoteric and complex applications, right? And that was not the point of the video that I did. I acknowledge that there are high order discussions to be had around that, but that just wasn't the point. The point was to take entry-level paramedic candidates through the process of working through a static cardiology exercises as they will encounter during the paramedic psychomotor examination. As it currently stands, there are some changes potentially occurring, but as it currently stands, as I'm currently talking about it. All right, so I hope that might clear things up quite a bit, that yeah, we recognize there are all these discussions we can have, but what National Registry is looking at is, can paramedics identify basic rhythms, and can they regurgitate the basic milk toast, quote unquote, treatment for these various rhythms. All right. So what does that come down to? That comes down to regurgitating AHA ACLS guidelines. Whether we like it or not, that is the core baseline competency, and it is American Heart Association algorithms that NREMT is going to use in order to justify whether or not a paramedic candidate passes or fails this station. So I want to provide the appropriate information to allow students to be successful, and that means following AHA guidelines. All right. So hopefully those caveats set up what I'm really trying to focus in on here, which is perhaps not something some of these folks are interested in discussing. I suspect some of them are more interested in discussing the therapeutic versus diagnostic implications of agents like adenosine when used in the setting of wide complex tachycardias, and that's perfectly legitimate field of inquiry. It's just not it's not a field of inquiry that might result in a entry-level paramedic doing well on a psychomotor examination for National Registry certification. All right, so with that caveat in mind, let's take a look at the current AHA guidelines as they pertain to tachydysrhythmias with a pulse. All right, everyone, welcome back. So here we are. We are taking a look at the current American Heart Association Advanced Cardiovascular Life Support algorithm in adult patients as it pertains to tachycardia with a pulse. So the algorithm starts here at the top, and it asks us to assess appropriateness for clinical condition. All right, and heart rate's typically going to exceed 150 per minute if a clinically significant tachyarrhythmia is present, and this generally is going to exclude sinus tachycardia, and I believe that's the reason why there is this limit of generally greater than 150. All right, so then it moves down, all right, to the first green box, which a green is essentially what you need to do. All right, these are the things that you need to do. So there's some tachycardic rhythm that exceeds 150 per minute. We generally suspect it is not a sinus rhythm where the SA node is in control, but something else. All right, so can we identify and treat underlying causes? Is the airway patent? Do we need to assist in breathing? If needed, does the patient require oxygen? We got to get them on a cardiac monitor. We need to get some vital signs like a blood pressure, pulse oximetry. We need to get vascular access and obtain a 12-lead ECG if available. All right, so we gather information and we ensure a modicum of stability. Then we move down to our first, anything in red is a critical decision point. All right, so red, persistent tachyarrhythmia causing, all right, hypotension, acute altered mental status, signs of shock, ischemic chest discomfort, or signs and symptoms of acute heart failure. If you can answer yes to any of these questions, then that tachyarrhythmia or tachydysrhythmia is causing the patient to be unstable and they require immediate electrical therapy, i.e. synchronized cardioversion. Okay? That was not the case in the stable monomorphic ventricular tachycardia rhythm in the video I referenced earlier. So we'll move down to no. And then this asks, is the QRS wider than 0.12 seconds? That's 3 millimeters or 3 small boxes. Yes or no? In this case, it was yes. All right. So we answered no to all these questions. So we have a stable patient with a wide QRS complex, and it says consider adenosine only if regular and monomorphic. All right. So the rhythm in question was a wide complex tachycardia. It was monomorphic. It was regular. Therefore, adenosine was indicated, and it is absolutely appropriate per AHA ACLS guidelines to administer adenosine in that case. Now, your specific policies, procedures, clinical practice guidelines, or protocols may not allow you to administer adenosine in that situation, but National Registry is not testing you for your specific agency, service, state, or municipality protocols or practice guidelines. Okay, these are looking at national guidelines as they come from American Heart Association, whether you agree with or whether you like that or not, right? That's not really the point of the specific testing in question. And then it also says something about antidysrhythmic or arrhythmic infusions and seek expert consultation. And then up here, this box gives you dosing. So adenosine IV, first dose 6 milligrams. Again, I fully acknowledge there are people that work under guidelines that state to start off with 12 milligrams, and that's perfectly acceptable. But again, right, I want my students to follow the letter of the law, so to speak, when it comes to this, in order to be successful, so they can successfully negotiate National Registry, get out into practice, and then learn the nuances after they have certified and licensed as a paramedic. And then you can see there are multiple antidysrhythmic infusions that can be considered for stable, wide, complex tachycardia. Some people in the comments stated that amiodarone was the agent of choice. Amiodarone is an agent that can be considered. There are actually 3 agents that you can look at administering. Procainamide is still on the guidelines, even though you may or may not carry it, right? You should still be familiar with it, all right? Amiodarone and sotalol, all right? So even though amiodarone is familiar to many of us, amiodarone is not necessarily the preferred agent, right? It is perfectly acceptable per AHA guidelines to consider procainamide or sotalol instead of amiodarone. All right, so it's a smorgasbord that you get to choose from. And again, it doesn't really care about all the nuances and so on and so forth, right? So this really is just a milquetoast, cookie cutter way of assessing and managing tachycardias. So this is the baseline that we want to see from paramedics as they are beginning their journey into paramedic practice. So hopefully I've emphasized that, and hopefully I have addressed any concerns or discussion around that specific video. All right, everyone, thank you all so much, and we will see you later.